Good afternoon. I'm Robert Rufo, and today I'll be talking about the impact of traditional demographic factors on emergency department boarding. On behalf of co-authors Dr. Aaron Shufflebarger, Dr. Lauren Walter, and Dr. Stu Booth, we thank you for joining us today and welcome you to this presentation. I have no financial relationships or interests to disclose. A little bit of background about our research. So it is well known in the medical literature that longer ED boarding times are associated with increased mortality and increased hospital length of stays. As you can see in the figure to the left, in 2011, Singer et al. Showed almost a linear correlation with in-hospital mortality rates and boarding times. Black patients have also been shown to have longer ED boarding times than non-Black patients. However, there's little additional insight in the medical literature regarding further possible disparities among patients who are boarding in emergency departments across the United States. Therefore, additional disparities may well exist. The objectives of our research our hope was to identify differences in ED boarding times among various demographic groups to gain a better understanding of possible underlying disparities. We also hope to provide further objective insight into factors that may contribute to adverse outcomes. We conducted a retrospective review of all ED admissions from a high-volume urban academic center in the Southeast from April to September of 2019. We looked at boarding time among demographic categories of race, sex, and age, and we used descriptive statistics and bivariate analysis with independent t-test and ANOVA. And we used JMP Pro 14 for our statistical analysis. Here is a chart just showing a general overview of the patients admitted during the study period. And so as you can see, we have roughly equal number of male and female patients. We had a higher percentage of white patients admitted during this time period compared to Black patients and other racial groups. And you can see that the median age was 58. And you can see a breakdown of admissions by acuity level as below. For results, for mean boarding time by race, Black patients boarded for a mean duration of 5.15 hours compared to white patients at 5.24 and other racial groups at 4.71 hours. These results are not statistically significant. There was no significant difference seen among racial groups as a whole. However, when looking at mean boarding time by admission type, we did find a significant difference among racial groups. As you can see, for medical admissions, Black patients boarded for a mean duration of 4.1 hours, white patients for 4.3, and other racial groups for about 4 hours. However, when looking at psychiatric admissions on their own, you can see that Black patients boarded for 22.67 hours compared to white patients at 18.49 and other racial groups at 17. And these results for psychiatric admits specifically are statistically significant. And when looking at mean boarding time by sex, you can see that male patients boarded for a mean duration of 5.46 hours compared to female patients at 4.9 hours. And these results are statistically significant. And when breaking down patients by various age groups, we did see some significant differences. Our patients who were 75 and older boarded for a mean duration of 3.76 hours. And when compared to the other age groups as above, they boarded for significantly shorter time than the patients in the other groups. We also found that patients in the 25 to 44 age group and the 15 to 24 age group boarded for significantly longer times than patients in the other older age groups. In conclusion for this analysis, we demonstrated significant differences in emergency department boarding times between races, specifically for psychiatric admissions, sexes, and ages. We hope that this data provides objective insight into differences in ED boarding times among various demographic groups, and we hope that this provides a focal point for examining possible clinical and social factors that may be contributing to the observed differences. Because the longer boarding times are linked to increased mortality, we think that identifying key elements associated with boarding time is essential to improving patient outcomes. Here are our sources. I want to thank you again for joining us, and we look forward to a further discussion.
Hello, my name is Jacob Gillen, and I'm a third-year medical student at the University of Massachusetts Medical School. And today I'll be presenting a qualitative evaluation of the barriers to and facilitators of starting buprenorphine in the emergency room. And I have nothing to disclose. So for background, buprenorphine has been associated with decreased morbidity and mortality in those suffering from opioid use disorder. And it's remained a largely underutilized resource in the emergency room especially. So our objectives were to improve the implementation of emergency medicine-based buprenorphine prescribing. And to do this, we needed to identify emergency medicine providers' perspectives on the barriers to and facilitators of providing buprenorphine from the emergency room. To do this, we conducted semi-structured interviews with a purposeful sample of practicing emergency medicine providers in the US using the implementation science framework. Interviews were recorded, transcribed, and coded by multiple members of our team using a directed qualitative content analysis approach. The codebook was developed based on the consolidated framework for implementation research, and each transcript was ultimately coded using the final codebook by 2 different researchers. We interviewed 25 providers, an average age of 43 years old, and providers were from 11 states and worked at 25 different hospitals or clinics. So common barriers, this is just a few of them, but the most common being buprenorphine waiver process, the fact that it took a lot of time or cost a fair amount of money. The availability and accessibility to follow-up and addiction resources, whether that be the presence of clinics, presence of providers, or transportation to the clinics, or availability of insurance on the patient side. Distrust of patients with opioid use disorder and stigma against them is pretty common. Lack of beliefs in one's own capabilities, and just the comfort surrounding the process of prescribing buprenorphine. The role of the emergency medicine clinician in treating opioid use disorder, i.e., this is not my job. Perception of patients with opioid use disorder as taking time away from other patients. The perception that opioid use disorder does not warrant emergent treatment. Logistical challenges. Lack of training, complexity of buprenorphine initiation. Perceived safety of buprenorphine, i.e., the fear of precipitated withdrawal or overdose, and the belief that buprenorphine is not efficacious. Some quotes that kind of highlighted some of the more common barriers is, how much is buprenorphine being abused? Are we enabling patients? Can we really trust them? Is it really something we should do? Because then all the drug addicts in the country are going to come to us. Are we actually making a change in that person's life? I still think we're just putting a Band-Aid on it. It sounds bad, but if it takes longer to have that discussion with someone than it takes to run a STEMI, then it's just not exciting in the mind of the average emergency physician. And I don't understand how it's different than other opiates. I don't know much about the pharmacology, but it's another opiate that causes physical dependence and withdrawal. So on the other hand, I want to highlight some of the common facilitators we identified. Free X waiver training, or the making it mandatory, or making it more emergency department specific, often was met with more of a positive attitude surrounding the process. The availability and accessibility of follow-up and addiction resources. Peer champions providing logistical support and feedback on patient status. A feeling of a moral imperative to treat patients with opioid use disorder, conveying the attitude that this is our job. Belief in the disease model of addiction and the desire to combat stigma surrounding opioid use disorder. Protocols and algorithms, both in the electronic medical record or within the setting that the provider practiced. Belief that medication for opioid use disorder is efficacious and safer than the alternative. And the role of influencers, whether that be conferences like this one, other resources, directors, administrators. So some quotes that highlight some of these facilitators. Whatever harm you can do with Suboxone, think about the harm they could do to themselves with IV heroin. By getting them on Suboxone and bridging them to that next appointment, you can save their life. It's the job of the ER, like connecting them to the cath lab. It's akin to saving their lives. These people are going to die, and I have a strong potential to save some people, young people, who have the potential to be good parents and functional parts of society. People on Suboxone are being judged by a lot of the medical community, physicians, pharmacists, nurses. They're being looked at as addicts. But I would say, think of this like a diabetic who needs insulin. This is like your blood pressure medication. I try to remove that sense of shame, that stigma. So in conclusion, there was a notable variation in attitudes regarding this practice, whether or not it was in the participant scope of practice, some noting that it constituted an important new skill, while others considered it a burden caused by the failures of outpatient addiction medicine or mission creep. Those with more experience provided more concrete implementation strategies. Many themes were commonly seen as both facilitators and barriers by different providers. And implementation strategies should address attitudes, training, follow-up, and logistics. And to end, who is going to start it if we don't start it? Thank you very much.
Hi, my name is Megan Hewlett, and I'm an emergency medicine resident at the University of California in San Francisco. My presentation is on cluster analysis of the highest users of medical, behavioral health, and social services in San Francisco. Myself and my research group have no financial conflicts of interest to disclose. So when we traditionally think of frequent users of the healthcare system and try to understand the drivers behind this, we generally recognize that these patients additionally have complex behavioral and social needs. However, the majority of research on this subject is largely focused on medical services usage, such as ED visits and inpatient stays. And despite the wide variety of interventions that have been put out there, such as cost sharing or care coordination, the amount of limited, robust research evaluating these interventions have shown that they've largely been ineffective. And what we're finding in San Francisco is that usage of medical services doesn't tell the entire story. In fact, in a retrospective analysis put out by our group in 2019, we found that frequent ED users also have frequent use of mental health, substance use disorder, and social services. To reflect this, we now characterize these patients as high users of multiple systems, hereafter known as HUMS patients for the purposes of this presentation. And this also reflects that our HUMS population is heterogeneous in multiple factors, including service utilization, and likely have differential management needs. Now, prior studies have identified subgroups within a population of frequent users of the healthcare system, and they largely characterize these subgroups based on comorbidities, demographics, and usage of medical services. And we wanted to take this a step further by using an integrated data set that incorporates data across multiple service domains: medical, mental health, substance use disorder, social services. And using this data set, we wanted to identify and characterize subgroups of the top 5% of HUMS patients in San Francisco County. With these integrated data, we could potentially characterize more informative subgroups and give us a better understanding of how to effectively address the needs of these vulnerable patients. We identified our patient population of interest by first calculating a HUMS score for all patients within our data set. This was calculated by adding up the total number of services used as defined in the table here for the 2019-2020 fiscal year. These data come from the Coordinated Care Management System, otherwise known as CCMS. This is a database implemented by the San Francisco Department of Public Health, and it's a database of complex, high-cost patients, and it compiles data across multiple service domains, so utilization data, as well as comorbidities, demographics, housing status. And using that HUMS score, as I detailed in the prior slide, we identified the top 5% of patients for fiscal year 2019-2020, which ended up being about 2,562 patients. And these patients were used towards our cluster analyses, in which we incorporated a k-means cluster algorithm using the cluster variables as detailed in the slide below. For our results, we identified 5 subgroups of patients that comprise the top 5% of HUMS patients for this fiscal year. Subgroup 1 is our youngest average age of patients with a racial ethnic makeup that's disproportionately white. They had mental health services use, disproportionate shelter use, as well as jail stay within the study period. Subgroup 2 was very similar to subgroup 1. They also had chronic medical conditions, as well as chronic homelessness, and they were also more likely to be HUMS patients within the prior fiscal year. Subgroup 3 was all female, had a racial ethnic makeup that was disproportionately Black. They also had mental health services use and chronic homelessness. Subgroup 4, these patients were disproportionately female, Asian, and Latinx. They were housed, they had chronic medical conditions and minimal usage of mental health or substance use disorder services. And for subgroup 5, this was our largest subgroup. They were majority male, racial ethnic makeup disproportionately Black. They had chronic medical conditions and substance use disorder, and they were also chronically homeless. So in summary, these findings highlight the need for cross-sector communication and integrated data in order to have a better understanding of the drivers behind high service utilization in these patient populations. Here we have the benefit of an integrated service database where we can look at database across all modalities of service provision. And this also highlights the heterogeneity in service utilization, as well as many other factors within our HUMS population. And this implies that these patients likely would benefit from multiple targeted approaches in terms of interventions, and that an off-the-shelf approach that's more widespread is less likely to be successful. Our results are preliminary, and our future work includes employing other cluster algorithms that are more capable of utilizing mixed categorical and continuous variables. And we'll compare those results to compare the robustness of our subgroups. I want to give a special thanks to Benioff Homeless and Housing Initiative and San Francisco Whole Person Care. Thank you.
I'm Ben Del Buono, and this is a qualitative analysis of frequent emergency department visits by patients experiencing homelessness. All authors report no conflict of interest. In 2017, there were an estimated 990,000 ED visits by individuals experiencing housing insecurity. Barriers to care, including housing insecurity, poverty, and food insecurity, are associated with increased ED visits. Little is known subjectively about the personal health care options and decisions of frequent ED visitors who are experiencing housing insecurity. The goals of this investigation were to identify, through qualitative research methods, how housing insecurity impacted this group's healthcare options, utilization decisions, and quality of care in the ED. Interviews were carried out at an urban Level 1 tertiary center hospital in Central Virginia. Eligible patients were at least 18 and experiencing housing insecurity at the time of enrollment or in the year prior to enrollment, and visited the ED at least 5 times in that prior year. Study personnel recruited participants by monitoring the ED tracking board for Emergency Department Information Exchange Alerts, also known as EDI alerts. These identify all patients who have visited that ED or any other ED in that area at least 5 times in the prior year. All interviews were audio recorded and transcribed. The coding scheme was implemented with a thematic analysis approach. Coded elements pertain to the original study question, thereby allowing a very large data set to be distilled into themes consistent across interviews. 11 participants were enrolled. 82% were male and 64% were Black. 73% reported substance abuse disorder, while 64% had some history of psychiatric disorder. 4 of them had a PCP, while 9 had some form of health insurance. The median number of ED visits for each individual within the 12 months prior to their interview date was 19, and this ranged from 7 to 75. A total of 5 themes were created from interview codes. The first theme was social determinants of health as drivers of ED visits. This included harsh living conditions, walking as a form of transportation, lack of education, and history of incarceration. It's not the most wonderful place. There's no heat and there's a problem with mold, so that's why I've been kind of sick too. I've been coming here a lot. I've had a cold and a really bad cough, chest pain, sore throat. You know what I'm saying? It's been hard. My current living situation is poor right now because I've been in the system a lot. Lack of education through all the situations I've been in. I got out of school in the 9th grade by being locked up and incarcerated. At the same time, my current living situation is poor because that's just us, African American. Theme 2 was visiting the ED out of desperation for safety, warmth, and food. This was for many in the setting of no family support of these basic needs. When I come here, I feel like I'm safe. Safe because the people can watch over me. Ain't nobody can come here to hurt me. So I come here for peace. When I'm here, I relax. Theme 3 was choosing the ED due to limited PCP access and perceived higher quality of care. Limited PCP access often involved difficulty with appointments and greater distance to outpatient offices. Perceived superior skills of ED physicians was also reported, despite many participants demonstrating an understanding that the ED is for acute care. You can't get appointments like you should. I don't think a person should have to wait. Too inconvenient. Very inconvenient. I can come to the emergency room. The one thing about it, you'll see me. Well, I would choose you because you seem to be more dedicated. It's really the dedication. Because I don't want anybody probing me, trying to figure out what's wrong with me. I want somebody to practically know. And you go to the emergency department, most of the time they know. Theme 4 is late utilization of the ED for medical care and social services. Many patients sought care from a PCP, specialist, or social services before visiting the ED and felt independent in managing most of their needs. I have no problem coming in here and saying I'm hungry. I have no problem coming in here and saying I'm cold. I have no problem with that, but it's not one of the things that motivates me. Yeah, the reason I can't really speak on medicine is because I'm not a doctor, but I'm an aide to myself. I just can't pick up the aid when it's an emergency. Theme 5 is wanting respect and maintaining hope. Participants felt that providers judged their lifestyle and seemed fatigued with their ED visits, yet they desired respect from them. Despite challenges, they identified hope in social work, housing, their children, and God to lead them to a healthier life. Talk to me, Don't just take for granted that everything's all right. You need to ask me questions. You understand what I'm saying about my healthcare? With being on both sides of having insurance and coming in, it just seems to me that you don't get the same care, like you're looked at different. And I think some of the doctors, I don't know if it's because they've seen me, but they're like, he's just back again. So you can kind of read it. In conclusion, healthcare utilization decisions by this group were often driven by access, convenience, and desperation. Participants commonly sought services from other resources before actually presenting to the ED. These interviews suggest that improved access to healthcare and social services, patient education, provider training, and housing availability are all involved in effectively caring for this vulnerable patient population. Limitations included that this was a single-site study. Recruitment also relied on using a combination of EDI alerts and chart review. It's certainly possible there were eligible patients experiencing housing insecurity where this was not listed in their chart. The study also only focused on adults, thereby not counting for children and families experiencing housing insecurity that may provide different perspectives. Thank you all for your attention today. I hope you enjoy the rest of the conference.
Hello, my name is Kaylin Folkley, and I'm the University of Washington Department of Emergency Medicine's Population Health Research Fellow. I will be presenting the results from our study titled That Line Just Kept Moving, Motivations of People Who Use Methamphetamine. This work is funded by Dr. Lauren Whiteside's K23. First, let me provide some background. Methamphetamine, or meth use, is on the rise nationwide, with increasing ED visits and deaths related to overdose. The Drug Abuse Warning Network, or DAWN data, demonstrated that almost 5% of all ED visits were related to substance use, and, compared to all other drugs, meth was responsible for the most visits. However, the opioid crisis has largely overshadowed the increasing prevalence of meth use and its related harms. And the previous literature has primarily focused on emergency providers describing meth use as a significant problem with high resource utilization, recidivism, and violence against staff, while excluding the perspective of patients. For this reason, the objective of the study is to identify the motivations of people who use meth and their experiences in the ED in order to guide future ED-based approaches. This is a qualitative study of adults residing in Washington state who used meth in the last 30 days, met criteria for high-risk use, recently visited the ED, and had access to a phone. 20 individuals were recruited to undergo semi-structured interviews, which were recorded and transcribed prior to being coded. Grounded theory guided the analysis, and the interview guide and codebook were refined iteratively. 2 investigators coded the interviews until consensus was reached. Data were collected until thematic saturation was achieved. The mean age of our participants was 41.5 years old, and most participants were white cis men. However, we employed purposive sampling based upon demographic information to include more diverse perspectives. 50% of participants reported that meth was their drug of choice, and 65% had injected in the last month. All participants reported experiencing homelessness in the past, while 40% are now unstably housed. Additionally, 90% are unemployed. 60% of participants reported ED use related to meth during their lifetimes, while 30% had visited the ED because of meth in the last 30 days. We found that participants described a shifting line that separates the positive attributes from the negative consequences of using meth. This was best summarized by one individual who explained, "I kept drawing lines of delineation. It was just going to be when I was hooking up, and then it was just going to be on weekends. Then it was just going to be not on work days, and then it was going to be I was never going to inject. That line just kept moving." In particular, we found 3 themes that straddled this line. First, many used meth to enhance their function, whether it be cleaning or studying, and providing protection in harsh conditions like homelessness. However, this hypervigilance can lead to overamping, when a participant might feel like they are overdosing, caught in a loop, and hyperactive. Second, many initially used meth to enhance social interactions by consuming with their network and augmenting sex, but continued use regularly led to isolation and stopping participation in life. Third, many used meth to escape difficult circumstances by numbing the senses and making everything okay that wasn't. However, the increasing need to use meth to self-medicate would lead participants to engage in increasingly risky behaviors, like sex work, to obtain the resources to purchase enough shots to avoid withdrawal. Additionally, participants frequently experienced discriminatory care because of their meth use. One participant explained, "As soon as they find out it was 100% drug-related, I get treated differently. When I'm there for a medical visit, I'm not looking to get high. Like, we'll go through procedures without pain medications." Another stated, "If I wanted to get high, I wouldn't go to the ER to do it." Because of their overwhelmingly frustrating experiences in the past, interviewees anticipated difficult interactions with healthcare providers, leading to avoidance of the ED at all costs and downstream healthcare complications. Nevertheless, meth use often drives patients to EDs, where they often feel stigmatized and like they are provided little assistance. ED providers should acknowledge addiction as a chronic disease, address symptoms adequately, and provide positive connections to outpatient resources. Future work should incorporate the perspectives of people who use meth into ED-based programs and interventions. Please email me with any questions. Thank you for your time.
Good morning, everyone. I'm Christiana Prutzner, and I'm a 4th-year medical student at Brown University. For my research, I looked at patients with opioid use disorder and their treatment in the emergency department, specifically the knowledge and attitudes of emergency department nurses regarding caring for this patient population. We have no disclosures. So first, why do we care about this topic in emergency medicine? Both opioid overdose deaths and emergency department visits after non-fatal overdoses are on the rise in the US. And this is still a very deadly problem. A study in the January issue of Annals by Weiner and colleagues found that 1 in 20 patients treated for overdose in the emergency department die within a year. The good news, we have evidence-based treatment and harm reduction measures with proven mortality benefits. So things like buprenorphine, syringe service programs. However, despite this, a significant percentage of eligible patients are still not linked to services during the time of their emergency department visit. So, why might this be? Previous research has explored this and namely looked at physician, advanced practice practitioner, and pharmacist factors to try and explain the gap. And their findings primarily pointed to factors such as lack of capacity, a lag in clinician training, and lingering stigma around substance abuse. However, little is known of nursing factors, which is perhaps surprising since a majority of patient interaction time in the hospital is typically spent with nurses rather than advanced practice clinicians. So to walk through our methods, this was a single site emailed survey. Our setting was a large urban academic medical center in the Northeast with high patient volumes, as you can see. We utilized a framework known as the theory of planned behavior to design our instrument. And this essentially says that an individual's predicted behavior depends on upstream measurable metrics of ability and motivation. So elements such as their beliefs, their knowledge, confidence, attitude, self-efficacy that can be measured and then subsequently are in part predictive of behavior. Here you can see a graphic of the framework. Our survey items themselves were novel and adapted previously validated survey questions that were sent in an emailed short survey. We then looked at our data with both a descriptive and an inferential lens. So, for example, how many nurses endorsed one attitude over another? How many nurses were aware, even, of their own emergency department services for addiction? And then we looked at whether factors such as a nurse's age, number of years worked, and prior education had significant relationships to their subsequent attitudes, beliefs, and knowledge. And what we found, and this is an extreme abbreviation of our results for the time here, our questions asked about nurses' knowledge, attitudes, beliefs, and confidence in various aspects of providing care in the emergency department to patients with opioid use disorder. We collected demographic information, including their age, years worked, prior education settings. 85 of 218 eligible nurses responded, and we excluded travel nurses. On average, nurses who responded were just under 36 years old, with a standard deviation of 11 years, and had worked for about 10 years on average in the emergency department. Again, a standard deviation of just under 10 years. And to highlight some key study outcomes, most nurses were willing and confident to screen for opioid use disorder on the order of 95 and 88% respectively. Most were knowledgeable about naloxone pharmacology. Most agreed with the biopsychosocial model of addiction and recovery science. Fewer, however, were familiar with some specific services offered in their own emergency department. So for example, the fact that patients could be given a take-home kit of buprenorphine to start after discharge was not well known. Interestingly, we also found that nurses who had received in-service training on addiction and opioid use disorder were significantly more confident providing buprenorphine to patients than those who had not. We also found that higher confidence providing buprenorphine and take-home naloxone was also significantly, but inversely, related to the number of years worked. So essentially, nurses who had worked for fewer years were significantly more confident providing buprenorphine and take-home naloxone than their more senior peers. Lastly, we found that nurses with knowledge of available emergency department services and more positive attitudes towards recovery science and harm reduction were significantly younger in age and worked significantly fewer years than those with less knowledge of emergency department services and those not indicating these beliefs. So to wrap up, emergency department nurses are willing to provide harm reduction and addiction treatment in the emergency department to patients with opioid use disorder. Confidence and measures and attitudes among ED nurses vary significantly across demographic factors such as age and work tenure. And in-service training related to opioid use disorder treatment may hold potential for increasing staff confidence. I'll say that generalizability of our study is somewhat limited by our single site design and our modest response rate. However, to our knowledge, this is the first investigation of its kind that examines nursing factors related to caring for this patient population. Next step, ideally, would look at whether any targeted staff development measures led to improved services linkage and better patient outcomes. And that brings me to the end of my presentation. Thank you for being here, and let me know what questions I can help answer. Thank you.
Hi, my name is Sarah Folman, and I'm a fourth-year medical student at the University of Chicago Pritzker School of Medicine. And I'm excited that you all are with me today, and I'm going to be presenting our abstract titled Characteristics of Patients Receiving Take-Home Naloxone in the University of Chicago Emergency Department. So first, I want to take a moment just to thank all of my co-authors who are integral in helping me put our abstract together. I also want to note that we do not have any disclosures. So for some background, opioid overdose education and naloxone distribution is known to be safe and effective to prevent overdose fatalities. Implementation of opioid overdose education and naloxone distribution in an emergency department can be challenging due to limited provider training, engagement, workflow, and stigma. So at the University of Chicago, we developed an opioid overdose education and naloxone distribution protocol. And today's analysis assesses the feasibility and patient characteristics of our naloxone distribution program in a high volume urban adult emergency department. So here are two of the educational resources that we put together for patients. So first is our video. If you're curious to watch it, you can view it at this link on the screen. We also put together discharge instructions. And these educational resources were to teach patients about naloxone, what it is, and how to use it. So today's analysis looked at patients screened between April 15th of 2019 and January 9th of 2020. Patients were eligible for free intramuscular naloxone if they met any of these 4 criteria. If they had taken opioids in the past year, if they had personally overdosed on opioids or mixed substances, including opioids, if they had witnessed an opioid overdose or bad reaction to opioids, or if they were a close contact of someone that uses opioids. We then use retrospective chart review to abstract data, and descriptive statistics and chi-square tests were performed. So 119 patients were given take-home naloxone during this time frame, and a majority of these patients did present for overdose or other opioid-related complaint. So 31% of these individuals watched our instructional video per what was documented in our EMR. 92% received discharge instructions according to our EMR. 45% had a prior history of opioid overdose. 8% previously received naloxone. 71% were male. 93% were Black. And I will note that this compares to 86% of patients who are Black at baseline in our adult emergency department. 83% of our patients had a heroin use history, 2% were on buprenorphine, and 3% were on methadone. We also looked to see how patients fared within 6 months of receiving naloxone, and 30% had an opioid-related emergency department visit, and 28% had a non-opioid-related emergency department visit. And notably, receiving our educational bundle of both the instructional video and the discharge instructions was not significantly associated with having a subsequent opioid-related visit to our emergency department within 6 months. So for our conclusions, opioid overdose education and naloxone distribution is feasible in a high-volume urban adult emergency department. We observed that a disproportionate number of Black, male, and older patients received naloxone, which highlights the importance of defining high-risk groups to help target screening for naloxone eligibility. Implementation of our educational bundle was not associated with an additional opioid-related emergency department visit, which underscores the limitations of our patient education. And finally, future research can help us better understand the impact and additional outcomes of the opioid overdose education and naloxone distribution intervention. And with that, I just want to thank everyone for attending today, and I look forward to answering any questions that you may have. Thanks.
My name is Brock Chmielewski, and I'm a third-year medical student at the UConn School of Medicine. Welcome to my presentation titled Utilization of Brief Screening to Assess Food Insecurity in the Emergency Department. We have no conflicts of interest to disclose. I'll start by defining food insecurity because that's the core theme of this project. In brief terms, an individual is food insecure when they cannot routinely access food because of insufficient resources, most commonly money. Rates of food insecurity vary every year in the US, but they routinely hover around 10 to 13%, and in 2019 it was 10.5% per USDA data. And this is associated with overall poor health outcomes. So how does this really impact the emergency department? Well, it's multifactorial and certainly difficult to parse out strict causation, but individuals or families with food insecurity often have to choose between paying for healthy food or paying for medications or for routine medical care or safe housing or childcare or plenty of basic needs that are just required to live a healthy and sustainable life. As a brief example, a patient with diabetes may have difficulty paying for a healthy diabetic diet and their insulin, leading to poor outcomes that result in more ED visits. Additionally, people at risk for food insecurity, particularly those with lower socioeconomic status, may have the ED as their primary point of healthcare contact, and thus the setting might be the only chance to reach a significant portion of people in need. With this in mind, the goals of the study involved 1, confirming that the ED population is in fact at greater risk for food insecurity compared to the general population, and therefore would benefit from increased screening and brief intervention. And 2, showing that these sorts of conversations can be done in a way that is still time efficient for a very busy ED staff. To accomplish these goals, we created a multi-site, prospective, cross-sectional survey study and enrolled a convenient sample of patients. Site A is a suburban academic ED that sees mostly adult patients, and Site B is an urban pediatric ED. We enrolled non-critically ill, English-speaking adult patients or parents or guardians of pediatric patients. The survey itself is anonymous, electronic, and contains 29 different items on demographics, participants' knowledge and use of local food assistance resources, their thoughts on the importance of this topic, particularly talking about it in the ED, and lastly, a food insecurity screening tool that's previously been validated by the USDA called the U.S. Household Food Security 6-item short form. And patients were able to complete the survey on their own device or by interview if unable to do so independently. The 6-item short form asks multiple choice questions about an individual's ability to afford meals and any potential experiences of hunger that they've had over a 12-month span. And a positive response to 2 or more of these items is scored as food insecure. Through this process, we recruited 150 total participants between 2019 to 2021, with an average age of 47 years old. The study population was 62% female, 60% white, 19% Black, and 15% Hispanic. For our primary study goals, the results showed that the rate of food insecurity was 27.3% at Site A and 25% at Site B. And both of these are statistically significant increases when compared to the general population rate of 10.5%. And our average encounter time was 3.4 minutes. Additionally, our results showed that over 2/3 of our participants definitively thought that this was an important topic to discuss in the emergency department, while only 10.9% thought that it was not. Overall, our results indicate that 1, there likely is in fact a benefit to be gained by increased screening and brief intervention for food insecurity in the ED because of higher risk in this patient population. 2, that this can be done in a time-efficient conversation of just a few minutes long. And 3, patients do really value when their healthcare team talks about this topic. However, our study at this point is limited by its use of convenient sampling that predisposes to selection bias. And the sample size is also too low to firmly predict generalizability or to make subgroup comparisons and food insecurity rates. However, given the low risk and overhead of this sort of screening and intervention, we do recommend its increased use despite these limitations. To improve the strength of our possible conclusions, we're in the process of adding an urban adult ED as a 3rd study site, and we're going to continue enrolling at all study sites to increase our sample size. That concludes my presentation. Thank you for your time, and I'm happy to address any questions.
My name is Rachel Anderson, and I'm a medical student at UMass. I'd like to thank my advisor, Dr. Payal Modi, assistant professor at UMass, who helped me with this project. This project is called Evaluating a Virtual Interdisciplinary Human Trafficking Training Program in the Emergency Department. I do not have any disclosures. Human trafficking is a global humanitarian crisis, with 40.3 million survivors identified worldwide. 87.8% of trafficking survivors report interactions with the healthcare system while being trafficked. And of those interactions, 63% occurred in the emergency department. As such, the ED represents a rare intersection where trafficked individuals have contact with an institution that may be able to provide help, and ED providers have a unique opportunity to identify these patients' needs and intervene accordingly. Existing literature shows that human trafficking education for healthcare providers is effective in increasing provider knowledge on the subject of human trafficking and increasing provider confidence in caring for trafficked patients. Even prior to COVID, online platforms had been utilized for human trafficking education and had proven effective. However, most human trafficking education has been focused on single provider types rather than interdisciplinary teams. An appropriate response to human trafficking in healthcare settings is multidisciplinary and involves coordinated action by a variety of provider types. As such, we sought to evaluate the effectiveness of a virtual interdisciplinary training program. In order to do so, we developed materials focused on trafficking identification, support, and trauma-informed care. This included instruction on how to follow our ED-based pathway algorithm for caring for trafficked patients. We then implemented 6 virtual interdisciplinary education sessions that were hosted in various online formats, including Zoom lectures and click-through modules. Attendees completed pre- and post surveys regarding their experiences and knowledge caring for trafficked patients. The trainings were attended by a variety of multidisciplinary team members, including attending physicians, residents and fellows, nurse practitioners and physician assistants, nurses, social workers, and emergency medical staff. 21% of pre-survey participants and 23% of post-survey participants had prior human trafficking training. Prior to training, 89% of providers reported that they had not asked about trafficking at all in the past 3 months, further highlighting the need for education on this topic. Mean provider confidence ratings for all 6 trafficked patient care tasks increased significantly by an average of 2.57 points. These tasks included identifying a trafficked patient, discussing trafficking with a suspected trafficked patient, caring for a trafficked patient who accepts your help, as well as a trafficked patient who refuses your help, navigating the resources available to offer trafficked patients, and understanding the multidisciplinary needs of trafficked patients. Significant increases were seen in the percentage of participants aware of the ED protocol, comfortable describing the role of healthcare providers, reporting a comprehensive understanding of human trafficking, and reporting past experience caring for trafficked patients. In particular, it is interesting to note that the percentage of participants who believed they had previously treated a patient who was being trafficked increased from 44% before the module to 66% after the module, suggesting that participants may have been previously unable to identify trafficked patients for whom they were providing care. Findings from this study suggest that most providers have not previously received adequate education on human trafficking, leading to missed opportunities for identification and intervention. Virtual, multidisciplinary modules can effectively address this deficit by increasing identification of trafficked patients, providers' confidence in caring for trafficked patients, and knowledge on the subject of human trafficking. However, even after completion of the module, further knowledge and confidence gaps remained, suggesting that more extensive training may be needed to properly equip providers to care for this unique patient population. Research is ongoing to consider long-term knowledge retention and increases in trafficking screening and identification following the training. Thank you.
Hi, I'm Spencer Ceballos, and I'm a fourth-year medical student at the Cleveland Clinic Lerner College of Medicine. Thank you for joining me today for this presentation entitled Characterizing Hospitalized versus Discharged Homeless Patient Emergency Department Visits in a Large Health System. My co-authors and I have no disclosures. On any given night in the United States, over 500,000 people are homeless. Individuals experiencing homelessness have high rates of emergency department utilization, hospitalization, substance use, and medical and psychiatric comorbidities. This population also faces health access barriers, including limited continuity of care, transportation challenges, and lack of insurance coverage, prompting many to utilize the emergency department for both high and low acuity health conditions. The objective of this study was to characterize the psychiatric and medical disease burden in homeless patients hospitalized compared to those discharged following an emergency department visit. We looked at ED visit data from between 2014 and 2019 at 18 Cleveland Clinic Health System emergency departments. We identified homeless patients through 2 methods. First, if their address was listed as homeless and they had an ICD-10 code indicating such, or 2, comparing their home or billing address listed in the electronic medical record with a list of homeless shelters and transitional housing in the region. Encounters were grouped by disposition, with admissions, observations, and transfers being in the hospitalized group, or discharges and those leaving prior to treatment completion being classified in the discharge group. Expired patients or those with unknown disposition were excluded. Demographic and diagnosis information was collected and analyzed for all visits, and descriptive statistics were calculated. Visit diagnoses were grouped into psychiatric, drug, alcohol, and medical classifications. During the study period, we identified 7,409 homeless patients who presented for 66,560 ED visits with a valid diagnosis code. The mean age for our patient population was 38.6, with an 18.3-year standard deviation. 63.6% of the homeless patients identified were male, 47.2% were Black, 43.4% were white, and 9.5% were of another race or unknown. In terms of diagnoses, 15.9% of patients presented to the ED with a psychiatric diagnosis, 3.1% had a drug-related diagnosis, 5.5% had an alcohol-related diagnosis, and over 3/4 of patients presented with a medical diagnosis. Looking at more detailed results between those who were hospitalized versus those discharged, 35.5% of patients who were hospitalized had a psychiatric diagnosis, compared with 9.5% of those who were discharged from the emergency department. 56% of those hospitalized from the ED had a medical diagnosis, compared with 81.8% of those discharged from the ED. Comparing ED visits resulting in hospitalization and those discharged, those with a psychiatric diagnosis were more likely to be hospitalized. There were similar rates of drug and alcohol-related diagnoses between those hospitalized and those discharged from the ED. 24.6% of all ED visits resulted in hospitalization. Looking at different diagnosis classifications, 54.9% of psychiatric diagnoses resulted in hospitalization. 22.2% and 25.8% of drug and alcohol-related encounters resulted in hospitalization, respectively. Medical encounters, on the other hand, only 18.3% of patients with this diagnosis classification were hospitalized following their emergency department visit. We concluded that homeless patients hospitalized after ED presentation have a high burden of psychiatric illness compared to those with substance-related or medical encounters. Gaining a better understanding of the medical, psychiatric, and social needs of homeless individuals may improve emergency department care and disposition planning for this at-risk population. Thank you for your time.
Good afternoon. My name is Sophie Morris, and I'm a research assistant at the University of Washington Department of Emergency Medicine. I will be presenting the results from our study titled A Qualitative Study of People Who Use Methamphetamine During COVID-19 to Inform Future ED Risk Mitigation Strategies. Here are our disclosures. First, let me provide some background. Morbidity and mortality related to methamphetamine use has been on the rise. When the COVID-19 pandemic started gaining notoriety in Washington state, the governor issued the stay-at-home, stay-healthy order, which encouraged social distancing to decrease transmission of the novel virus. 42 states and territories had a similar guideline. Many discussed the appearance of two pandemics, that of COVID-19 and that of substance use disorder. The aim of this study was to explore concerns in COVID-19 risk mitigation strategies with patients who use methamphetamines to inform emergency department-based harm reduction approaches for this vulnerable population. Wanting to explore the impact on the Washington community, our sample frame was anyone in Washington with self-reported ED visit in the last 3 months, meth use in the last 30 days, and moderate risk for methamphetamine use disorder. Patients were recruited through flyers and community services. The survey and interview were conducted over the phone. Then we used a grounded theory approach to guide the qualitative research process. A constant comparative analysis was used to code the interviews. To elicit perspectives from a diverse population, we employed purposeful sampling to ensure a wide distribution of race and sex. Here we have some highlights of the demographic information. Half of the interviewed participants stated that their drug of choice was meth by itself. 65% of the 20 participants had injected in the last month. All of the participants reported being homeless at least once in their life, with 40% of the 20 participants citing that they were currently unstably housed. After reaching thematic saturation, we noticed 3 themes emerge within the topic of COVID. Increase in meth use, including using to cope, to comply with the new guidelines, loss of routine, and lost opportunities to connect for recovery. Interplay of meth attention and COVID, including a description of risk mitigation strategies, are continuing as usual. And a third theme around interactions with healthcare and social services, which are influenced by, on the one hand, historical mistrust in institutions, and on the other, the difficulty with internet-based recovery tools. The next slides will show some representative quotes derived from the interviews for each theme. This quote highlights how interviewees reported an increase in meth use to tolerate isolation and comply with the social distancing guidelines and loss of routine. Although the participants reported use of meth to assist with tolerating isolation, they recognized this compromised their recovery trajectory as they increased their use or started using again. As this person says, "It helps me to follow these rules a lot better." In parallel with mask wearing, where some people opt to wear masks and others do not, the same was reflected in the participant pool, where people who use meth are split between those adapting COVID-19 prevention guidelines to their substance use or in obtaining meth, whereas others simply continue as usual. Like this participant put it, "So I don't let people use my pipes, and I try to keep my distance." Many participants reported history of mistrust in healthcare in general and avoiding healthcare institutions. Of this mistrust, many reported avoiding healthcare or public health messages and started coming up with their own explanations on why COVID-19 began, why some people got infected compared to others, amongst other things. As this participant said, "Some secret going around about it." While COVID-19 brought a boost in telehealth models, improving some access for certain population, it also limited access to others, which is what we observed in our population. Many participants cited difficulties in accessing internet or smartphone devices, which then limited their access to recovery resources. We are seeing that this tech divide needs to be addressed as it is limiting opportunities to access recovery. For instance, this participant said, "That group where we meet in person, there's at least one person, possibly still high. I haven't seen anyone like that since COVID-19 started." To summarize, people who use meth are at risk for COVID-19 and for meth-related harm due to increased use and mistrust in healthcare institutions. We recognize our study had some limitations, including sampling only people who had access to phones and the inherent limited generalizability of qualitative work. However, we have a couple important hypotheses generating conclusions. In order to improve transitions of care for ED-initiated patients and operationalize risk mitigation strategies in the new COVID world, we need to build strong relationships between community champions and emergency departments to increase trust. We need to implement non-traditional public health messages, and we need to continue to conduct patient-centered research on the complex interactions and on the patterns of people who use meth. Please email me with any questions. Thank you for your time.
Hello, I'm Spencer Ceballos, and I'm a fourth-year medical student at the Cleveland Clinic Lerner College of Medicine. Thank you for joining me for this presentation today entitled 30-Day and 1-Year Healthcare Utilization Prior to Death of Homeless Patients in the Emergency Department. My co-authors and I have no disclosures. In the United States, it is estimated that over 500,000 people are homeless on any given night. This population experiences premature aging and early mortality compared to the general population. This homeless population also has high rates of substance use, medical and psychiatric comorbidities, and emergency department utilization. Although ED care may represent the only health system contact point this population has prior to death, the health needs and peri-mortem health system utilization of this population are poorly understood. The objective of this study is to describe demographics, visit characteristics, and prior healthcare utilization of homeless patients who died in the ED in a large regional health system. This study looked at patient visits to 18 emergency departments in the Cleveland Clinic Health System, including 2 Level 2 trauma centers from 2014 to 2019. We identified patients who are homeless through 2 methods. First, their address is listed as homeless and indicated as such with an ICD-10 code. Or 2, we compared the patient's billing or home address to a list of addresses of regional homeless shelters and traditional housing. Patients whose ED disposition was expired or with the presenting diagnosis of respiratory cardiac arrest were included. Those who were resuscitated and survived to hospital admission were excluded. Patient demographics, past medical history, ED presentation characteristics and pre-hospital care, as well as prior 30-day and 1-year healthcare utilization, including outpatient visits, ED visits, surgeries, hospital stays, and psychiatric admissions, were collected from the electronic medical record with a standardized data collection form. Descriptive statistics were calculated.
Over the study period, we identified 7,506 homeless individuals who presented for ED encounters, and 48 were pronounced dead in the emergency department. 34 or 71% of these individuals were male, and the mean age of death was 46.5, with a standard deviation of 16.4. 25 or 52% of these patients were white, 19 or almost 40% of these patients were black, and 5 patients or 10% were multiracial or another race. Patients generally presented with out-of-hospital cardiac arrest, with 92% of patients who died in the ED with this presentation. 12 of these, or 25% of the total, were associated with a drug overdose. 3 patients, or 6% of the total, were due to trauma or gunshot wounds. In the 30 days prior to death, 17 patients, or 37.5%, had any healthcare utilization. 16 of these, or 33% of the total, had 1 or more ED encounters, indicating that patients who had healthcare utilization in the 30 days prior to death were overwhelmingly likely to have this occur in the emergency department. In the year prior to death, 29 or 60% of patients had 1 or more ED encounters, and 88% of patients with any healthcare utilization had an encounter in the emergency department. 16 or 33% of patients had more than 10 outpatient or ED encounters in the year prior to their death. Conversely, 15 patients, or 32%, had no documented healthcare utilization in the year prior to their death. In our sample, homeless individuals experienced early mortality. Prior to death, a large proportion of homeless decedents did not have recent health system contact, suggesting those with high mortality risk may underutilize health services. Conversely, a similar proportion of homeless decedents had extensive or greater than 10 health system contacts, representing possible opportunities to reduce mortality in this population subset. Future directions for this research, including expanding our database with other regional health systems, including level 1 trauma centers, to better identify specific mortality risk factors in this population. Thank you for your time.